Every year, more than 100,000 people are diagnosed with leptomeningeal cancer, and yet we do not have the tools to prevent, diagnose, or treat this disease. The Leptomeningeal Cancer Foundation is here to change that. Working with medical experts, researchers, patients, and their families, we will raise awareness, educate patients and healthcare providers, and support research. Please visit us at lmcancer.org and follow us on social media. We are here to support you and ensure that you never feel alone. Hi, everyone. Welcome to today's webinar. We are so grateful that you are taking the time out of your day to join us. I'm Helene Bader. I'm the founder and president of the Leptomeningeal Cancer Foundation. And I started this foundation earlier this year in honor of my son, Theo, who died last year at age 17 from leptomeningeal cancer. And our work is now focused on providing all of you with the information you need to navigate this difficult disease. And we're also supporting research and advancements in treatments. As you know, all of the webinars we've had so far have featured doctors from the United States and clinical trials in the United States. And many people have been asking about how to access care outside of the US. So we're starting with Europe, as many doctors in Europe see patients from countries around the world. And hopefully this is a start to providing information and access to people everywhere. So before we dive in, just a few things. We do have live captioning available, so please use the closed caption icon box to turn on captioning, or click the view full transcript under the captions and translation. Please use the Q&A function for your questions. You can enter them as they arise, and we'll get to as many as possible. We'll be asking questions throughout the presentation and not holding them till the end. And if you sent one in with registration, we'll have those ready to ask as well. And please know that our presenting doctors cannot provide medical advice on this webinar. So if any questions are too specific to a personal situation, we won't be able to answer them. And on that same note, just a reminder that the information you hear today is not intended as medical advice or as a substitute for medical care. Please speak with your own personal doctor about healthcare decisions and your personal care plan. So thank you for understanding. Today, we are fortunate to have two amazing experts with us. First, Dr. Emilie Leroun. Dr. Leroun is a neuro-oncologist at the University Hospital and University of Zurich. Prior to this, she was a senior neuro-oncologist at the Department of Neurosurgery at the University Hospital Lille, France, and at the Cancer Center Oscar Lamberche, Lamberg since 2005. She is member of the European Association of Neuro-Oncology Guidelines Committee and a member of their guideline task force on glioma, brain metastases, meningioma, and palliative care. She's also a member of the steering committee of the European Organization for Research and Treatment of Cancer Brain Tumor Group and leads the Brain Tumor Group CNS Metastases Committee. Dr. Leroun's main research interests are brain and leptomeningeal metastasis, including the role of liquid biopsies. So welcome, Dr. Leroun. We also have with us today Dr. Thibaut Picard. Dr. Picard is Associate Professor of Neurosurgery and Histology at the Hospice Civil de Lyon and at Lyon University in France. His clinical activity is dedicated to the surgical management of primary and secondary brain tumors. Regarding his research, he studied the inter- and intratumoral heterogeneity of brain tumors during his PhD program. And after obtaining his doctorate degree, Dr. Picard studied neuron-glioma interactions during his postdoc internship at the University of California, San Francisco. Dr. Picard is a member of the Brain Tumor Group of the European Organization for Research and Treatment of Cancer, where he serves as a young investigator. Thank you both so much for joining us. Dr. Leroun, I'll turn it over to you.
Very much for this really nice initiative and for inviting us to this webinar. So we hope it will be interesting for everybody. So I will start to share my screen. So this is my disclosure slide. So thank you. So I think the first topic that we have is how to diagnose leptomeningeal metastasis. So this is what we do in Europe, but I think it's quite similar to what is done also in the US. So first, what is important, I think, for everybody to understand when you look at paper, some news, some what is hot, and you have to understand what doctors have analyzed in their work, because not everybody is using exactly the same definition of LMD. So that's really a first step. So sometimes it's based on MRI aspect only, sometimes on the cerebrospinal fluid only, sometimes both, and sometimes you can use three, so clinics, imaging, and CSF cytology. And I will show you why this is important to understand your study population, in fact, data from which patient were analyzed. So we have in Europe this EANO, so that's the European Society of Neuro-Oncology, and ESMO, the Medical Oncology Society, that we have done together, and we try to put some neurologists and also medical oncologists and radiation oncologists, of course. And what is important to us that so we need to have these three pillars to really assess the diagnosis. So we need to have a clinical evaluation, and we have signs and symptoms that can be typical, others are not. We need to have a brain and spine MRI to look at the entire axis, because the cells and the disease can go to the entire axis. So it's important not to have not only a brain, but really everything. And the CSF cytology. Oh, sorry, I was too quick. So here it's very important. It's not that painful for the patient normally. And so here we need to collect high quality CSF and to provide quickly with the analysis, and then we can assess the diagnosis. And also what I want to show you is to assess so the diagnosis and also the response to treatment during the course of the disease. We need to have homogenized and standardized tools. And we have also currently, so now scorecard for the clinical assessment, which is called NanoLM. And we also have validate a scorecard for the imaging assessment. So the idea is that we don't say this is the truth, but at least everybody's looking at the problem the same way, and that's the idea behind this standardized examination. So this is what we have in the EANO-ESMO classification. So we have first what we call a type 1 of leptomeningeal metastasis with positive CSF, meaning tumor cells in the CSF, and in that case, the diagnosis is confirmed. And in the type 2, so here's the CSF, so cerebrospinal fluid, we do not see tumor cells, or that's equivocal, we are not really sure. And in that case, the diagnosis will be probable if we see these typical signs on the MRI, and otherwise can just be possible. And here we also define a lack of evidence. And then the question whether it makes sense. And we saw that, so type 1, when we have tumor cells in the CSF, and type 2, the prognosis is different. That's why it's important when you look at publication to see if the CSF has been studied or not. So here I stop, and I don't know if you have some questions, Hélène?
Yeah, we do have some questions that came in. One of the questions is about liquid biopsy. Are you doing anything with liquid biopsy yet, or just cytology in Europe, as that's been coming up a lot in the United States?
Yeah, so I think at the moment it's to assess the diagnosis is difficult, because in fact whatever you have, the technology are not all the same. We have no clear standardization. There are several techniques. You can look at what the tumor cells, so to see if you have tumor cells in the CSF, yes, no. But to understand if they have tumor cells, you have to put some markers on these cells, and sometimes it doesn't fit. It's not ideal. It's not. You can have some cells that do not match what you expected. So what do you do with these cells? So that's a bit complicated. And same when you look at ctDNA, or what we call the extracellular vesicles, it's also something that you cannot be 100% sure that it comes from what is in the liquid, but it could be also you have done a vascular bridge. So for the diagnosis, for the moment, I think we need more, but for the follow-up, I think that's interesting. And then what we can also say for the diagnosis, that's nice to have this ctDNA in the CSF, so to look at this genomic alteration, because sometimes we can find a target that can be used for the treatment. So you see, it's more to guide the therapy. In fact, I think it's more useful at the moment, but hopefully we will improve.
That's great. And one other question, kind of similar, but there's been some questions about next generation sequencing testing, NGS. And do you recommend doing it on CSF, and do you offer that in Europe?
So it's done. I'm not sure it's fully approved now. So there are some, you have techniques, but I think it's nice to have, especially if you have a new diagnosis, but if you are looking for a target and you know what you are looking for. And now they are trying really to develop the test for the CSF, like it's done in the blood, but I think you need some final technical validation. But the problem is that if you see a target at the moment, yes, it's there and it can guide you for the treatment. If the target is not there, you cannot be sure it's not there.
So that makes sense. So for now, we're sticking with MRI and cytology and the neurologic exam, and then hopefully integrating these into the future.
Yes.
Okay, great. Well, that's all the questions. You want to move on to the next section?
So good morning, I think, for everybody. So thank you for giving me the opportunity to present this part. So as Hélène said, I am a neurosurgeon in France, and we will speak about the surgical procedures that can be proposed in the settings of leptomeningeal disease that are ventriculoperitoneal shunts and Ommaya port. So let's start with the ventriculoperitoneal shunt. So the first question you may have is, what does this device, what is this device for, sorry? So many patients who have leptomeningeal disease developed hydrocephalus. So on the left part of the slide, you can see a normal MRI scan from the brain. So in everybody, we have cavities in which there is CSF. And in case of hydrocephalus, you can see on the right that these cavities are bigger than in a normal person, and there are several causes of hydrocephalus, but typically this is one of the features that can be associated with leptomeningeal disease. So VP shunt is only a treatment for hydrocephalus. It is not a device in which you can inject treatment, but there can be severe signs associated to hydrocephalus, and ventriculoperitoneal shunt is useful for that. So how does ventriculoperitoneal shunt work? So ventriculoperitoneal shunt is composed of ventricular catheter, which is connected to a tube that goes to the peritoneal cavity, which is a cavity that is around the bowel, and the CSF, which is in excess in the ventricle, can be drained to the to the peritoneal cavity where it is resorbed. So the peritoneal cavity has normally resorption abilities. So how to do it surgically? We have to perform a ventricle punction with a specific tube, and then to make the tube pass under the skin to the peritoneal cavity. And in patients in who we perform those surgeries, there are two scars, one on the head and one so on the abdomen. So reservoir is put at the junction between the two parts of the shunt. So it is a small device that is just under the skin, and the pressure can be modulated to adapt the speed of the drainage. So this reservoir is provided by different brands. In Europe, we have the Sofisa, Codman, and Mitke providers, and another brand can be found notably in the United States. So thanks to this device, it is really possible to adjust the speed of CSF drainage, and it's important because it's not the same in every patient, and if it is too low or too high, it can lead to symptoms, notably headaches. And this kind of device is compatible with MRI. So leptomeningeal disease patients have a lot of MRI for the follow-up, and it is possible to have an MRI with this system. And there are some special reservoirs that can be used without any issues. So we use these in this patient, but in some cases, some reservoir can be dysregulated by the MRI, and in that case, it has to be checked after MRI to make sure that the speed of the CSF drainage is still the same. So regarding the procedure for the patient who will have a ventricular peritoneal shunt, it is asked as for every surgical intervention to check coagulation parameters and platelets with a blood test before the surgery. Then the morning of the surgery, there is a skin preparation with a shampoo and a shower. Only the scar is shaved on the head, sometimes on the abdomen in men. The procedure is performed under general anesthesia. There is a prophylactic antibiotic therapy directly in the operative room to avoid infection of the system. It is relatively quick, so it may last more or less 1 hour. And after the surgery, so X-rays are performed as well as cranial CT scan to make sure that the device is correctly positioned. So here you can see an example of a brain CT scan with the ventricle catheter in place. And here you have example of X-rays, so which shows the ventricle tube, the reservoir, and the distal tube that goes to the peritoneal cavity. So for this kind of procedure, patients, at least in France, stay at the hospital 2 or 3 days. And there are some stitches or staple on the skin, and these have to be removed around 10 days after the surgery. So as for every surgery, ventricular peritoneal shunt can lead to some complication. There can be a suboptimal position of the tube, either in the ventricle or in the abdomen, which can need to revise the system. As for every surgery, there is a risk of infection, so it is important to check seriously the scars and the temperature to make sure that there is no issue. And after the shunt placement, there can be some mechanical complication. So one of part of the system can be broken, but it's pretty rare. So after a ventricular peritoneal shunt, patients have to rest. They should avoid smoking, which can interfere with healing. And it is required to avoid to pass through electromagnetic gates, because this kind of device can lead to modification of the speed of CSF drainage. So where is it possible to get ventricular peritoneal shunt? So it is a very common surgery that is made also in other conditions, and many cranial neurosurgical centers propose it in France, in the United States, and in any other country. So then let's talk about the Ommaya ports. So the Ommaya ports is a different device that can be placed either in a cranial position or in lumbar position, so under the skin at the level of the spine. And Ommaya port can be used for several purposes. They can be used to place medication, to inject medication directly into the CSF. It is also possible with that system to take a CSF sample or to remove excess CSF, and it is also possible to measure the pressure in the brain. So the most common configuration that we use is the cranial one. So there can be some mechanical issues with the lumbar configuration. So the volume of the reservoir is around 1.5 to 2.4 milliliter. So for the procedure, many steps are similar to ventricular peritoneal shunt. So it is the case you have to perform checking for coagulation and platelets. The skin preparation is the same. These surgeries are usually performed under general anesthesia, but it's sometimes possible to do it under local anesthesia. It lasts less than an hour. And after the Ommaya port placement, it is necessary to have imaging to make sure that the system is correctly placed. So if that's the case, the hospital stay is not long, so 1 or 2 days in France. And as for VP shunt, the stitches and staples have to be removed 10 days after the surgery. And before using the system, it is necessary to wait for at least a few days. And before injecting any treatment through it, it is necessary to check that it is possible to aspirate CSF. So regarding the complications, there can also be some optimal positioning, infection, or mechanical complication. And the recommendation after an Ommaya port placement are pretty much the same for VP shunt. And it is also, I would say, classical procedures that can be performed in most cranial neurosurgical centers. So I think it was all for me.
Thank you so much. This is really helpful. Everyone should remember too that if you have questions, please put them in the Q&A. You can also put them in as anonymous or with your name. So, and then we'll get to those whenever those come in. We do have a few questions that came in earlier. One is, can you have a VP shunt and Ommaya at the same time?
Yeah, totally. It's not a problem. So the objectives, the purpose of the two devices are different. So you can put the two devices in the same patient. It's not a problem at all.
Okay, so it won't be a problem with cycling the medicine out if it's the shunt is kind of pulling fluid. It won't pull the medicine out of the cerebrospinal fluid.
Yeah, no, I don't think so. But the best would be probably to have one on one side and the other one on the other side. Maybe it should be a security.
Okay. And then we've heard from a lot of people that their doctors in Europe will not put in Ommaya ports. It seems like it's a lot more common in the US. Do you know why that is and where it's more available versus where it's not available?
In which center you mean? I'm not sure to have understood the question.
Yeah, so we've just heard from a lot of people in Europe, in different countries, that they have trouble getting Ommaya ports put in, that a lot of people, a lot of doctors will not put in Omayas, they don't have access to getting them put in. So I was curious if you know why that is, why there's not as much access to it, and if there are certain centers or certain countries that it's more common in within Europe.
No, I do not have the answer. Maybe Emily could help. Maybe it depends on the protocols that can be offered in the different centers, I think.
Okay. So, but in France, it's a common thing and you're doing it quite often for these patients. Okay. And if people live in other countries, can they come to you and get that? Is that something that could work if they live in other countries within Europe?
Oh, yeah, yes, it's something that is possible to organize, yeah.
Okay, great. And then another question was in terms of the Omaya, does that stay in the entire time that you're getting treatment?
Yes, it's not really not a problem. The part that is under the skin is really small, so it does not cause any discomfort. And after the treatment is done, it is also possible to remove it, but there is no issue to keep it for several weeks or months.
Okay. And then the final question is, if you don't get a VP shunt and you only have an Omaya, can you treat hydrocephalus through the Omaya? Is it possible to monitor the pressure using the Omaya only?
Yes, it is totally possible. So through Omaya, it is also possible to remove CSF if there is an excess of CSF, but of course, it's more practical to have a VP shunt in that case, and it is also possible to inject treatment and to measure the pressure. So different things, these different things are possible with an Omaya.
Okay. Well, that's all the questions right now. I'm sure we'll have more as the presentation comes up in terms of the VP shunt and the Omaya. So we'll turn it back to Emily and we will have her present on the treatments as well as the other parts of the presentation.
So now we will discuss a bit the options that are available for the patient. And in Europe, we are obviously using the European guidelines. So we have three approaches. So intrathecal pharmacotherapy, systemic pharmacotherapy, and radiotherapy. So first, let's start with intrathecal therapy or intra-CSF therapy. So here the goal of the treatment is really to deliver the drug at the right place where we want it to be. So really in the contact of the meninges in the cerebrospinal fluid. And here you can see on these slides, for example, you can see trastuzumab, so Herceptin. So here, if you look at what you get in the vein versus what you get in the CSF, you see you get 1% of what you can find. You can find only 1% in the CSF of what you can find in the vein. So it's really not a lot, and we have a lot of agents like this, even some, now it's a bit improving with the new one, but you see a lot of drugs that are currently used simply do not penetrate the CSF. So the evidence, so we did a clinical trial, so in France, some years ago already. So it was with liposomal cytarabine, which is not available anymore. And here we wanted to look, it was in patients with breast cancer and a new diagnosis of leptomeningeal metastasis. Patients were randomized between a control group. So here they had the systemic treatment only or systemic treatment plus intrathecal. And our primary endpoint, so the goal of the study was to look if the leptomeningeal metastases are controlled longer. And this was the case. So you can see here in red, so the curve of the patient with both systemic plus intrathecal, it was better than for patients treated with systemic treatment alone. And we also found the same. So in a retrospective cohort that we had, so in patients with tumor cells in the CSF, they also live longer if they receive intrathecal treatment in addition to systemic treatment. It was a trend, but in this retrospective cohort, it was not significant for type 2 LM, so without tumor cells in the CSF. And at the moment, so we have a lot of new agents, so it's really moving. So there is a lot of intrathecal trastuzumab, so with this anti-HER2. We discussed a bit with Ellen before, also a lot of happening with intrathecal pemetrexed, notably in Asia. And we have also a new treatment with intrathecal immunotherapy, so also done at MD Anderson, and one that we have done also in Zurich in Switzerland. So regarding now more pharmacotherapy, so we have some clinical trials, as you can see here. Here, for example, that in breast cancer, and we have different agents. But also what I want to share with you here, and this column is important, the number of patients. So it's really very small number. And phase 2, for example, it means that they all receive the intervention. So they all receive the treatment. And the problem is that often, of course, you select your patient that you put in the study. And also remember what we discussed before. So here it's not, they say all positive CSF cytology or positive MRI. But if it's only MRI, they also, you see, it can a bit bias, and we have to understand how many of these patients had positive CSF cytology or not. So that's something, work that we did with Rupert Bartsch from Vienna. So we looked at these studies, and it's mainly, so we have prospective and retrospective study, but the problem is that most of the publications, they don't tell you how the diagnosis was performed. They say, yes, it's based on CSF cytology and MRI, but they don't tell you how many patients had both and what was the result for both. But I think this is improving, but just to keep this in mind. Now, regarding craniospinal therapy, so here it was very old cohorts, published also small numbers of patients, and it's not proton therapy, but tomotherapy. And here, if you look at the number of patients, also the number of patients who could complete the treatment, so get the treatment as planned, it's not all the patients. So here it was almost only half of the patients that could go through the treatment as planned. And at the end, the survival was not really improved, but a lot of toxicity, and notably hematological toxicity. And so that's why now with the craniospinal proton irradiation, that was, of course, you have heard about this study. And so the control of the leptomeningeal disease was improved. Here it's just that I think we need to have, again, more data, because they compared, in fact, here they compare, so patients, they had also positive cytology, positive MRI, but you see most of the patients, they compared, so the craniospinal irradiation versus a whole brain. And the problem is that at the moment in Europe, for example, we do not recommend whole brain irradiation anymore for us, because it doesn't work. So for us, it's a bit difficult to interpret this data. It's randomized, but still it's randomized against something which is known not to work. So I think we need to have more data. We cannot say it's good or it's difficult to have an opinion on the efficacy, because we need to compare to standard treatment, because you can also see that systemic therapy has to be stopped during the craniospinal irradiation. And again, here you can see that up to 10% of the 10 to 11% of the patients had to discontinue the CSI because they could not go through it. And it was only 5% in the, for us, whole brain, or which is not what we like. And then, so how to combine? We have this recommendation in Europe. So it's defined by the type of leptomeningeal metastasis that you have, so CSF positive with tumor cells or not. And here we always discuss the three angles. So intrathecal therapy, yes, for patient with tumor cells in the CSF, probably for patient with no tumor cells in the CSF, but with linear disease, probably not, you see minus, for patient with nodular disease only and no tumor cells in the CSF. We always propose to change and adapt to systemic therapy. And we don't propose whole brain radiotherapy anymore, only focal radiotherapy on nodules. So here I stop. Hélène?
That was really helpful and interesting. I have a bunch of questions for you. Um, so first, I wanted to understand, we don't really talk about in the US as much the type 1 and type 2, and I'm curious about um, do you see better results for patients if they have it only in the CSF or only on the MRI? Is that, how does that work and what kind of response are you seeing when you compare one to the other?
So the prognostic is better if you do not have cells in the CSF.
Okay.
That's clear. Yeah.
That's helpful. Um, and then what are the criteria that the neuro-oncologists consider when evaluating the appropriateness of inserting an Ommaya port? So at what time do you decide that's the right direction to go in?
So I think here we have, of course, to discuss with the patient. In Europe, it's not a must before that you get Ommaya before you start intrathecal therapy. In Europe, so I think it depends on the agent. If you need to have like 2 injections per week, like for 4 weeks, and continue, yeah, that makes sense to do it as soon as possible. But you see, if you have a treatment, it's 1 injection every 3 weeks or every 4 weeks, and it's just a lumbar puncture. It's well tolerated. I think the patient has a word to say. At the moment, we have all data saying that drugs, but it's sub-analysis of studies. So we have to be careful again, but still that drug with a short half-life, so drugs that are quickly eliminated, it's probably better to do it via an Ommaya, but drug with long half-life, it doesn't make a difference. And now the new drugs that we are seeing, like all this immunotherapy, trastuzumab, they stay long in the CSF. So I think I think it's nice to see if you can stabilize a bit and to avoid, because that's a lot of things when you get the diagnosis and you have to do this, you have to put your Ommaya before you start. That's I think emotionally a lot for the patient. So I think we have to discuss. Yeah.
Absolutely. And I want to go back to the other question. That was really interesting. But I just realized I forgot one piece of the question. So you were talking about it's easier to treat if it's only on the MRI and not in the CSF. What if it's nodular? So you're actually seeing tumors. Does that make a difference or is that the same thing?
A nodular tumor. So here we try to work also. That's what we do a lot in Switzerland. We ask the radiation oncologist to treat the nodules locally with SRS, so stereotactic radiotherapy on the nodule. And we combine, we all play together in the same team. And yeah, that's what we do.
Okay, that makes sense. And then does it make sense to test, or do you do this, test in vitro for the chemo or drug sensitivity before actually administering? Can you do that?
Incredible that you asked this question, because so not yet for leptomeningeal metastasis, because it's more difficult. You need to have enough tumor cells in the CSF to be able to to do this drug screening that you are talking about. And just in fact, like 2 weeks ago, we opened a trial in Switzerland, again in Zurich, but for patients with brain metastases. So here, and patients who have an indication for a brain surgery for this metastasis. And here we take out brain metastasis, not me, but a neurosurgeon. And then we do a drug testing. So we are testing 56 drugs on the plates, and we see which drugs is most interesting for the patient. And then the plan is to treat the patient. And so now it's recently open, but now so for brain mets, yes, and hopefully for LMD soon, but not yet.
Yes, we need to get it there as well. And then one other question is access to proton CSI pretty available throughout Europe, or is it really centered in certain areas? Because I do hear people having difficulty getting access to proton. And we have the same issue in the United States, but how is that in Europe in terms of getting access?
It's not necessarily the main indication. So you have some proton centers and of course several patients and several diseases, and most of the time they prioritize children, the young patients, and tumor that they can be cured but they cannot be removed, for example, because they have bad locations, so the neurosurgeon cannot take them out, but the prognosis is very good otherwise. So that's usually the priority to do for. I think it's difficult at the moment in Europe to treat patients with LMD, but remember also what I just said before. At the moment, I think we don't know if that's really better, because it was compared, this randomized trial was compared to something that we know doesn't work.
Yeah.
So I would like to see, yes, intrathecal plus systemic plus the addition on top to see if it makes sense to have the three, to combine the three, or I think we need to have more data, and yes. Yeah.
Right. And I know I've heard before too, it's just more important to get the treatment than necessarily get the proton over regular radiation at this point until we know more, as you said. Okay, well, great. Well, I think those are all the questions for this section, so we'll keep moving.
Good. So now open and recruiting trials. So how to find them? So first we have this clinicaltrial.gov. So that's something that is nice. I must say it's quite intuitive. So you have a home page. You can put the disease that you want to look at, where you want to have some information. So at the moment in Europe, you have so these trials that are open. I must say our trial now, it's close to enrollment, still open, but not for new patients. And you have one trial in Germany, one trial in France, and also you see a CSI trial in Denmark also that is enrolling. So the easiest what we do as clinicians, this is how we know there is a trial usually. We also have European website for clinical trial register, but I must say it's less user-friendly. It's a bit more complicated to find something. Here I put an example for the Tuxedo trial. Maybe you have heard about that, and it's a bit more difficult than to have the information on the trial. In Switzerland, we have another website that's called Human Research. So I must say it's, the best for us still clinicaltrial.gov. And I think here we need also, and that would be great, and I think, Hélène, that you could help also. I think people who have clinical trial open would be happy to provide you with trials that are open at their centers and keep you up to date, or we have to see if we do it also we could do it via SNO, via IANO, to discuss if somebody could do like a registry for this patient. And then that's when to look for a study. So when I'm diagnosed with a disease, or to know what in the future, what would be the option, or only when I have the leptomeningeal metastases. And I think, and because you have to be quick also, so it's really difficult because you have several options you want to discuss, but you have not really the time to discuss. Find a study to see if the study is appropriate. So I think that's important to have clinicians that are honest and explain to you where the program is standing. If it's something very new and we have no data, no efficacy data, no safety data, and we have no idea if it works or not, or something that you could get and it looks exciting and it's already advanced, because you have to enter the program. So that's a lot of emotion. Sometimes you have to leave your house to go to another city. So we have this logistical and financial burden that is not always covered, and most of the time not covered. And also we have to see if the study participation is feasible or not. And I think this is something that we could discuss with you, Hélène, also to provide some recommendation how to find out for a patient if makes sense, at least for the first step, or to say, no, it's not for me. So here we should really discuss, yes, about this registry communication, to have some education on the purposes of the trial. So what is a phase 0, what is a phase 1, what is a phase 4, and I think everything can be on the wonderful website of Hélène. So it's, and how to read and understand inclusion criteria. And if you want to have to enter a trial, what kind of document you need. And again, here I'm happy to discuss and to have the feedback.
Thank you, and thanks for the shout out to our website. We are trying. And we do have all the open trials on the website that we can find on clinicaltrials.gov. We've talked about an automatic clinical trial finder at some point because right now it is manual. I just update it once a month. I go through and I pull them all, but I think there's a much more effective way of doing that, of course. And I love your idea of having, kind of the purposes of the trials, talk about the different stages, the phases of 0, and onward, and then the list of documents. So those are things we could absolutely add to the site. One question, are the trials listed on the EU Clinical Trials Register or the Human Research different than the ones on clinicaltrials.gov, or are they the same?
No, they are the same.
Okay.
It's just what is different between Europe and US. No, it's the same, and I think that it has to be international, and this is how you can avoid to repeat exactly what somebody else has done, or you can contact this person to see what could be improved and or things like that. They also have a clinical trial website in Asia, in China exactly. So, but here's often the studies that they are doing, they are apparent on their Chinese clinical trial website, but not on the clinicaltrial.gov. So that's the only difference.
Yeah, and we do see a lot of trials in China on the clinicaltrials.gov website. What about Australia? Do you know where that lands in terms of clinical trials? Because we haven't seen any for.
No, but I think they also put everything on clinicaltrial.gov.
Okay, so there just aren't any yet at this point.
Yeah.
Do you have to be a resident in the country the trial is happening? Or, for example, can I join a trial in Germany if I'm from France?
You can. I think the best is to contact the person, and it can be that you have to pay, in fact, for the logistics, for example, for the hotel, the train, the flight. But normally for all trials, all academic trials, and all even the industry trials, you do not have to pay for the drug that you receive.
Okay.
This is always covered, otherwise there is a problem.
Yeah, absolutely. That's good to know because I know that there aren't that many trials yet and we need more. So it's good to know that people can access them in other countries, even if they're not a resident there. And then one of the things that I'm passionate about and I'm working to make happen, but it hasn't really happened yet, is bringing pediatrics into the mix, as we know that a lot of children are affected. Like my son was pediatric when he was diagnosed, and we hear a lot of kids with sarcomas and brain tumors that end up with leptomeningeal. And do you know of any trials in children that are available at this point? And do you work with the pediatric oncologist at all, or is it very separate in Europe as well?
The latest, yeah. Still, we are trying to improve. We are trying to talk more to each other, but still, yes, it's still too separated. But
Well, that's one of my goals.
working.
So I will help make that
Yeah.
happen because we're kind of trying to do that in the US as well, because I think that the pediatric oncologists really aren't talking about this enough. And I'd love to bring them into the conversation. All right, so that's all for this section. So we'll finish up with the next section.
Good. So that's also something that you have on your website. So to look for European experts, so how you can reach people and go for telehealth for other countries. So that's a website of Hélène. So I think it's really well explained when you want to have a second opinion. So everything is there. Don't have to add anything there. What here I show you what we have in Zurich. So in Zurich, at the University Hospital, we can offer to see patients, so in person or virtually via this e-visit telehealth, except for US patients. So this we have to tell. And then we have this international office, and you see they explain a bit. So that's of course everything is perfect. You see fast and uncomplicated access to all the specialists. So very impressive. And they tell you a bit what we have to provide, and you can write an email or you can fill this form that's on the website. So everything is easy, and you will they will get in touch with you and organize teleconsultation with specialists that you want. And so of course this has also a cost, but they will provide you of course a cost estimate depending of what you want, in fact. And this is also on the website from Hélène. So we already discussed to have like a list of worldwide center. I have not put the US sites, all the others. But I think honestly, if you are in a country it's not listed here, or you are in a city that it's not listed here, I think that we can always discuss and try to find somebody and just reach out to one of them and ask, do you know somebody in this country that's not complicated, to at least to try to find an expert. And that's it from me, Hélène.
Oh, thank you. Well, I think some questions for that. I do feel like we are trying to increase the number of doctors listed there. I'd love to be able to have doctors obviously in every country so that we have experts everywhere. So anytime you hear of anybody or you learn of anyone, please make sure you share so we can add that to our website. One question, is there a list somewhere of all of the LMD experts in Europe? Anywhere that we don't have here that you feel like are missing? No?
No. I think you have everybody, and if we hear new colleagues, I think we will tell you.
Okay, good. What about for people, like if someone lives in Australia, for example, and I keep using that because we see a lot of patients that are in Australia in different regions and have difficulty getting care. If they do telehealth with you and you have treatment recommendations, can they work with their doctor to get that treatment at the local hospital?
Yeah, of course we do that. We can just provide recommendation, and then they can talk to the local doctor, and doctor that we will take care of them, and we provide advice. And if the local doctor finds this advice correct and interesting, yes, of course, this is something that we can do. Yeah.
Okay, good. And then we did have a question that we know the centers in the US that are leading centers, for example, all the MD Anderson, the Memorial Sloan Kettering, Moffitt. We know that kind of center of excellence is in those different places. Are there leading centers in Europe for LM that you would say?
I would say probably the centers of the people that you have on your list. So because the experts are there. And so we try to connect, but I would simply go through your list.
Well, that's good to know. Yeah, and we'll continue adding, as I said. So I don't think we have any other questions. I wanted to see if you and Thibaut, if you'd like to, Dr. Picard, if you want to join as well back in and just kind of give any final words for people who are dealing with this or living with this. What would you suggest, or are there any direction that you can provide for them before we sign off?
Yes, I'm sorry. No, I think everything was said, so it is sometimes a good option to have a second opinion, and it is always useful to do that for MLM as for any other disease. So it would be the more relevant advice I can say.
Okay, thank you. And Dr. Laron?
No, for me, I'm really happy that we do that together, to have you. It's really nice because we need to have you, we need to have the patient, and we have to work together and to see how we improve things. So yeah, it's
Absolutely.
activities. Yes. Yeah.
Well, thank you all so much. I really hope this was helpful for everyone who attended and that you're leaving today feeling more informed. And I want to say thank you to our incredible panelists and our amazing producer, and especially our audience members. I know that's always hard to take time out of your day, but we do appreciate it. You can follow us on social media, sign up for our newsletter, check out our website. Thank you, Dr. Lauren, for pointing that out with all our different pieces in there. I think there's a lot of good information. We're just updating every day as much as we can, and we will keep you up to date on all of our upcoming events. So thank you, everyone, and have a wonderful day.